Good evening and a very warm welcome on behalf of ESGE. I like it very much that you're joining tonight. There are many people attending as far as I can see. And this is the next ESGE Papers of the Month webinar. And we are going to discuss two very nice papers, one on the colon and one on the biliary tract. And I think those are two topics that are important for clinical practice. The first two speakers that I will introduce are Dr. Julia Gauci. She was working at the time in Sydney with Michael Borg. And the second speaker, that's the discussant, that's Dr. Leon Moots from Utrecht. And the paper that we're going to discuss first is a paper entitled Prevalence of Endoscopically Curable Low-Risk Cancer Among Large Non-Pedunculated Polyps in the Right Colon. And that was published ahead in Clinical Gastroenterology and Hepatology. By the way, my name is Peter Siersema, and my co-chair is Helmut Messmann. And I kindly introduce Dr. Julia Gauci for the first presentation, please.
Hello, good evening. Thank you, Professor Siersema. My name is Julia Gauci. Many thanks to the ESGE for the opportunity to present our paper entitled The Prevalence of Endoscopically Curable Low-Risk Cancer Amongst Large Non-Pedunculated Colorectal Polyps in the Right Colon. This paper was presented in CGH last month. Large non-pedunculated colorectal polyps, or LNPCP, are established precursors for colorectal cancer. Most of these lesions are confined to the mucosal layer and therefore cured by endoscopic mucosal resection. Some centers are increasingly advocating for universal ESD for the management of all LNPCP. The rationale behind preferring unblock over piecemeal resection includes the lower rates of recurrence, which may in turn impact surveillance protocols, as well as the lower risk of piecemeal resection of submucosal invasive cancer. Historically, piecemeal EMR was associated with high recurrence rates in the order of 10 to 20% at 6-month surveillance colonoscopy. However, with the advent of margin thermal ablation, this risk has greatly reduced. In the landmark trial investigating the impact of margin thermal ablation, the rate of recurrence reduced from 20% in the control group to 5% in the treatment group. This effect was subsequently replicated in real-world studies. This graphical abstract here is a real-world international multi-center cohort of 1,000 LNPCP, and the recurrence rate at 6-month surveillance was only 1.4%. A recent randomized controlled trial by a North American group comparing margin thermal ablation with STSC versus APC or no treatment at all showed that the lowest rate of recurrence was achieved in the STSC group at 4.6%. The Resect Colon trial, which is the first randomized controlled trial comparing unblocked piecemeal resection by the French group, demonstrated acceptable recurrence rates at 5.1%. However, even lower recurrence rates were achieved with ESD at only 0.6%. This, though, came at the expense of an increased rate of adverse events. Looking at the final requirement for surgery, either for adverse events or oncologic outcomes, this was the same in both groups. The technique with margin thermal ablation is crucial. After performing high-quality EMR where no macroscopic tissue is evident, a 3 to 5 millimeter rim of uninterrupted denatured tissue must be created along the defect margin to achieve these low recurrence rates. Even if recurrence rates of 0 are achieved, this does not negate the requirement for early surveillance colonoscopy. And the reason for this is the rate of synchronous disease. We know that patients with LNPCP have a 7% risk of having another large lesion and a 40% risk of having another advanced adenoma within the first 12 months of follow-up. Therefore, both European and American society guidelines still recommend piecemeal EMR as the first-line modality in the case of benign LNPCP. So what about those at risk of cancer? Submucosal invasive cancer should be divided into low-risk and high-risk cancers. because of their risk for lymph node metastases. The low-risk cancers are those containing superficial submucosal invasion, less than 1,000 micrometers, low tumor grade, no LVI, and no or low-grade tumor budding. If removed en bloc with clear margins, they can be deemed cured by endoscopic resection. On the other hand, high-risk cancers are those with deep submucosal invasion, or a high tumor grade, or LVI, or high-grade tumor budding, and they require surgical resection and lymph node clearance to achieve cure. Universal ESD may result in the overtreatment of benign lesions, particularly in the right colon where the risk of SMIC is low. However, a universal EMR protocol may result in a high rate of piecemeal resection of otherwise endoscopically curable cancers. So the aim of our study was to determine the proportion of right colon LMPCP with low-risk cancer, which would have been cured if resected by unblock or not ESD. We conducted a retrospective analysis of a prospective cohort from expert tissue resection centers. The patients were referred for endoscopic resection of LMPCP. We defined the right colon as any lesion proximal to the splenic flexure, and the decision to perform endoscopic resection or refer directly for surgical resection was at the endoscopist's discretion on the basis of the presence or absence of features of overt SMIC. We included both the patients who underwent an attempted endoscopic resection, as well as those that were referred to surgery. Over a 15-year period in 7 expert centers in Australia, Belgium, and Israel, over 5,000 sporadic LMPCP were referred. And on the right, we're looking at the pathway for patients included in the final analysis. On the arm on the left, those are the patients that went for endoscopic resection, and on the right are the ones that underwent surgery. In total, there were 2,956 sporadic right colon LMPCP in the same number of patients. On the right, the table is showing the patient and lesion characteristics of this entire cohort. There were around 30% of cases which had any nodular component and 30% non-granular cases. The prevalence of cancer in the right colon was 4.4%. On this next table, we're looking at the patient and lesion characteristics, comparing 2 groups, the patients who went direct to surgery and those who underwent an EMR. Of note, not surprisingly, those which went directly to surgery were more likely to have a 2C component, to be non-granular, or to have a more advanced Kudo-type pit pattern. Detailed histopathologic analysis was possible in 115 out of 131 cancers. The prevalence of low-risk cancer in this cohort was 0.78%. Out of the 23 low-risk cancers, 4 of them were cured by unblock or not EMR. And again, another comparison table between these 2 groups, this time looking at the detailed histopathological features. Those cases that went direct to surgery were more likely to have deeper invasion within the SM or even beyond the submucosal layer. Interestingly, there was no difference between the 2 groups in any of the other high-risk histopathological criteria, including tumor grade, LVI, or tumor budding. Considering this whole cohort of right colon LMPCP, the need for additional surgery after endoscopic resection to achieve a curative resection would have been 3.8% if they all underwent EMR and 3.1% if they all underwent ESD. Therefore, if a universal ESD strategy was employed, the number needed to treat to prevent 1 additional surgery would be around 142 patients. In conclusion, out of almost 3,000 right colon sporadic LMPCP, the overall rate of cancer was 4.4%. Of these cancers, of the total cohort, 0.78% were low-risk cancers. ESD is a resource-intensive procedure. It mandates a hospital stay and has a higher risk of adverse events. Therefore, In light of our findings, a universal ESD strategy cannot be justified for the management of right colon LMPCP. Studies focused on pre-resection prediction of low-risk cancer in the right colon are required to facilitate selective ESD. Thank you very much.
Thank you very much for your presentation. We move on to Dr. Leo Monzo for his commentary. I'd like to point out to the audience that if you have any questions, there's a Q&A box, and if you do have questions, please ask them, and we will try to discuss them at the end of this presentation. And then there's most of the time we have time for that, so that will be great. Okay, Leon, please give your commentary.
Yeah. First, I want to congratulate Julia and all the people of the ACE cohort, of course, very known. And I want to point out some important aspects of the study. Of course, I have nothing to disclose except that I'm a consultant in Boston Scientific and Pentax Medical. Of course, there's an ongoing discussion whether we should do EMR or ESD. And as Julia eloquently showed, that of course EMR is widely available, safe. It's not very time-consuming, low costs, and not dependent on location. Downsides are the piecemeal resection, less optimal histological assessment, and a high local recurrence rate, although it is declining with new developments and innovation of EMR, like the margin ablation, but also the underwater EMR technique. On the other side, we have ESD, which has a high unblock rate, optimal histological association, low local recurrence rate, below 0, but there is high need of expertise, longer time, more complication, higher cost, and of course they are much more difficult in the colon. And when to consider both techniques, I think we have to look at two outcomes. One, of course, is the oncological treatment, which I think is the topic of today, or to lower the risk of local recurrence. And as I think, as Julia showed, the EMR is so close, getting so close to ESD. The fact is whether this would be the ideal endpoint to say that ESD is necessary is going to debate it. However, on the oncological outcome, there's a lot of discussion, and then of course we have these 3 strategies. One is EMR always, or EMR if benign, but if suspected, do ESD. That's selective ESD approach, or do ESD always. And this paper argues against ESD always. So what do we know beside this paper on the prevalence of T1 colorectal cancers in proximal LMPCPs? And then we know already that it is quite low. Also in the paper from Jacques, the France RCT, the prevalence of cancer was 6%. In our own paper published in the Gut in 2019, it was only 6% in LMPCPs in the proximal colon. And of course, Burgess already from the same group published that it was 5%. So this is expanding data showing that of all large lesions in the proximal colon, only a small part of them have cancer. So I do believe that the majority of them show no cancer, and of course they can be easily treated by EMR. But of course, in real life, we look at the polyp and try to disseminate or discriminate. First, is there a risk of cancer? And is there a risk of covert submucosal invasive cancer? Although we don't see it, it might be there. Is there signs of invasive cancer? And are there signs of deep submucosal invasive cancer or even beyond, like T2 or T3? And then we decide which technique we should use, which is the most appropriate. And if you look at this paper, you can see that the ones sent to surgery were actually indeed needed to be sent to surgery because the vast majority of them showed T2, T3, and even a T4. So it's unlikely that this group would also be eligible for ESD. So this is, although they were referred for local excision, I think that was underestimated by the referring hospital. And these are not the cases which we should try to do a local excision on. So this is the group where we do EMR, and so there was no other lesion selected for another resection technique. So this is an always EMR approach. And if you look in this EMR approach, you can also see there was a group showing features of potential submucosal invasive cancer. There were about 138, so 83 of them were indeed treated with local excision. And as we can see that about a quarter of those cases were indeed cancer, the cancer what we see. So if you look at the EMR, which is unsuspected based on optical diagnosis, it was even lower. The risk of cancer was 1.9%. So I think we can really say that if you don't see any signs of cancer, the risk of cancer in a proximal located polyp is really low and should not be an argument to say we do an ESD. If you look at the EMR on the other side, the technical success was disappointing with 77%. The zero rate, which was also shown by Julia, was low, but there was also a high risk of residual cancer at the surgical specimen, about 31%. However, this also included 10 cases with T2 or more cancers. So about 15% of them showed recurrent lesions after EMR of a T1. Then the question is, when is a local excision curative? And in the current paper, the curative rate is about 25% of all locally excised T1 cancers, and that is a little bit low. If you look at the Jacques paper, which also applied the same risk stratification, it comes down to 54%. And if you look at the paper, the meta-analysis of Fukio, and they estimated that it was about 11% of SM1 cancers. They showed that if SM1 cancer was present, about 75% of them didn't show any histological risk factor. So 75% of the superficial invasive T1 colorectal cancers could have been curatively treated. And we also know from our cohort that about 70% of the SM1s and 40% of the SM, just deep submucosal invasive, do not show any other risk factors. It's very difficult to conclude it from the Ohata paper because it doesn't really discriminate between proximal located LMPCPs and lower LMPCPs, but the recurrence rate in SM1 was also higher. So if you look at those cases, for example, in the same cohort, and you would have had a selective approach, then you have to treat 83 cases, which 1 out of 4 would have shown cancer. So the questions, I think, from this paper is not only that the universal ESD approach is not appropriate for LMPCPs in the proximal colon, and I totally agree with that, but I also think that they showed that an always EMR approach is also not very appropriate. So I think that we somehow have to come to a selected ESD approach in the colon, even also in the proximal colon. And I think that the niche, of course, is small. So you could argue whether everybody should do this ESDs or it should be somehow combined in a few referral centers, which can build up a lot of experience and lower can increase the speed and lower the risk of complications. And of course, there's also a shifting panel on what we consider a local excision to be curative. And especially in the proximal colon, that is very important. And I think that EMR will not help us in those cases when you don't have an A0 resection. But that's open for discussion. Thank you.
Well, excellent questions, and again, excellent presentations from the two of you. And I suggest that we start with the first question, Julia, how to select proximal suspected LMPCPs?
Yeah, I'm just thinking it's the most difficult one because
it is, yes.
We sort of, what we found was that it's so hard to find criteria for selection, partly because the rates of cancer in the right colon are so low. So doing a significant logistic regression to pick up those really high risk lesions is quite difficult. In a recently published paper where we looked at the whole colon and grouped based on morphology and surface Paris classification and morphology, the only high risk lesions in the proximal colon were non-granular and nodular lesions. So the 0-1S component, which were also non-granular. And it was found that the rate of invasive cancer in those lesions was around 20%. And when we looked at that subset, so in that study, they defined the proximal colon differently. They defined it as proximal to the rectosigmoid. So when we applied that to this cohort, proximal to the splenic flexure, the rate of SMIC was 10%, which is higher than the rest of 4.4%. But then when we looked into those 14 cancers, only one of them was a low-risk cancer curable by endoscopic resection. So it didn't impact the number needed to treat at all, even if you were selective. And even if looking at the Kudo pattern, we tried to look at the Kudo 5i pit pattern to see if that was selective enough. It actually didn't perform that well. So I think we're good at detecting maybe depth of invasion, which was demonstrated in that table where we saw the ones that went directly to surgery were more likely to have deeper invasion. But I'm not sure that the other high-risk criteria manifest themselves as surface features as much. And I think that's where the difficulty lies. Those cases with LVI or poor differentiation perhaps don't appear too different to one without those high-risk features.
So basically what you say is that selecting the appropriate resection technique is still not so easy and still, well, not completely sorted out.
Not so easy, but I think it's the right direction. I don't think a universal anything is ever an answer in medicine at all. There's no one procedure that fits every patient and every lesion, and that's what we should be striving to perfect our selective algorithms. That should be the goal.
Yeah. Okay, we should, I think, in the sake of time, move to the second question. Who should perform ESD in the proximal colon? I think that's also a long answer possible, but what is your opinion?
I think this one is a bit easier because we know that in the proximal colon, the rates of adverse events and vertical margin involvement are higher. So it's a no-brainer that it should be done by high-volume centers. And there's a very nice paper from the French group by Ludvico, I think was the first author, and they demonstrated very clearly that the difference between low volume, medium volume, and high volume has a significant impact on block or not, curative resection, procedure time, perforation, bleeding. So where there is higher risk, they of course should be done in high volume quaternary referral centers.
You would like to comment on this answer from Julia Leon?
Yeah, and I totally agree. I think she clearly showed that the number of cases which are eligible for ESD in the proximal colon are very small. So and I think it's much more difficult to perform ESD in the proximal colon. And especially when you encounter perhaps a little bit deeper invasion, it becomes more and more difficult. You try to prevent to damage the muscle layer. So I think that these cases especially should be referred to centers who can do a lot. So I would really argue for centralization for colon ESD, perhaps not rectal ESD, but colon ESD. It should be especially in the proximal colon, to my opinion.
Yeah, I completely.
What do you think?
Yeah, I completely agree. I think we had in Germany also a ESD registry which showed the same as Julia said. There is a clear a correlation between volume, center, and outcome of curative resection rate or complications. So that means ESD in proximal colon is only in expert hands safe. I'm wondering, Julia, we have shown in our data from the rectum, if we have a proven cancer, in the majority we couldn't cure even with ESD because it was always or the majority were high risk cancer. So if you have a proven cancer in the right colon, would you go for resection? And do you think it's still feasible to do EMR if it's a proven cancer?
I think it depends on the patient and their comorbidities. Because we've shown before that if there's a dominant nodule that appears like an overt cancer, and that's taken off on block. The rest piecemeal, deep margins are clear, and there's no LVI. There tends to be no residual cancer when they had surgery, and there tends to be no recurrence outside of the colon either. But of course, the risk is not zero. So I think if they're young, healthy patients, then we should be offering them a curative resection by the defined criteria, and that would be on block. But if they're older and more comorbid, I think it's reasonable to do so in a piecemeal fashion, if they're counseled appropriately.
Yeah, and maybe another question is, of all these studies, how big is the influence of a selection bias? I think each center is specialized for something. So I would say we in Augsburg do a lot of ESD, so we get more and more advanced lesions. If you are an expert in another technique for thickness resection or whatever, could this influence the prevalence and the outcome? Being special?
I'm sure it does.
Yeah.
I think in the majority of cases were done in Australia, and most of them were from the primary from Westmead Hospital, and all of the expert centers offer both ESD and DMR.
Yeah.
And there's no, particularly in the main center, there's no competing ESD center where they would be referred to otherwise. I suppose the other question is, are they being referred for surgery?
Yeah.
We have the data for the volume of colorectal surgery, which is performed on benign polyps in the New South Wales region, and that's around 10%, which is comparable with other European centers and definitely much less than the Americans, where it was like 25%, I think.
Yeah.
So that doesn't seem to be a huge volume. It's still too high, but there doesn't seem to be a huge volume that are bypassing referral to a tissue resection center and going straight to surgery.
Yeah.
Okay, I should suggest that we also ask the third question that Leon wrote down here. When to decide if a local excision is curative, especially in the proximal colon. So
I wonder if perhaps partly one reason why our rates of superficial SMIC, the proportion from superficial to deep, is a bit skewed towards deep, is maybe because we have this part of our cohort are older patients, and we do occasionally piecemeal resections on those cases. So within our EMR cohort, there is a higher proportion of deep SMIC, whereas maybe in those other studies, those have just been sent to surgery and we're not appreciating them there. And the reason the outcomes of the Gibson paper and gut. I think decision about if it's curative or not for the time being should be based on the current guidelines, the European and the Japanese guidelines, but it is looking increasingly like deep submucosal invasion alone will potentially not be considered a criterion, given that the rates of lymph node metastases are lower. And we did look at that in our group. If we included patients with deep SSMIC as being cured, if they had no other high-risk criteria, the rate of curative resection would have gone up from 0.78 to 1.7%, and the number needed to treat drops to 63 from 142.
So we have.
If may I comment on that?
Yeah, of course.
Julia, what you just gave an example of older people, and then you think, okay, you don't want to operate on them because they have a higher comorbidity. Wouldn't that rather be an indication to do an unblock excision? Because then there's a high chance that you are finished. Instead of you doing an EMR, you also saw a recurrence rate of 15% of the residual cancer of 15%. And I do think that a lot of them, because after EMR, you know now that some of them have T2 or T3, but that's uncertain after the EMR itself. And so you don't know for sure. You only see cancer in the specimens, but you cannot really reliable say how deep it is really going.
So we would only count it as we would sort of only say it's, I can't use the term cured, but we know that the outcomes are okay longer term if the deep margin was clear. So if the deep margin was involved, then those patients are likely to have recurrence in the surgical specimen. So why not do ESD? It's mainly because of the practice for EMR versus ESD in Westmead, and it's the same in the UK actually, that for EMR, it's either deep sedation or even conscious sedation. So we do these cases with a very small dose of midazolam and fentanyl, a short procedure time, so that the sedation side is much safer for the patient, whereas a proximal colon ESD would probably need to be done under a general anesthetic, as well as a slightly increased risk of intra-procedural and delayed perforation. So it is a more invasive procedure for these more elderly and comorbid patients.
Okay, thank you very much. I think we can discuss this paper for a much longer time, but we are restricted in time, and we have to move on to the second paper. There are 3 questions in the Q&A box. Julia, can I ask you to answer those 3 questions in the Q&A box and type your answer?
Yes, of course.
Thank you very much.
Thank you.
So Helmut, can you please introduce the next paper?
Yeah, okay, we come to the next topic after this first highlight in the colon, and we have also a very interesting topic which is on hepatobiliary diseases. That means bile duct stricture, and the paper we present now is endoscopic ultrasound versus ERCP-guided primary drainage of inoperable malignant distal biliary obstruction, a systemic review and meta-analysis of randomized controlled trials. And this is published by a group of international experts from Italy, France, Israel, and Hong Kong. And the first author is Tawfik Khoury from Israel, and he will present now the analysis of this randomized trials. And Tawfik, thank you for taking the chance and giving us the opportunity to present this hot topic here, a brand new paper which is now published recently. So thank you for sharing the time with us. And then the paper will be discussed by Ulrike Denzel. She is the head of the department of the endoscopy unit, University Marburg. She is also a very well-known expert in the field of EOS and ERCP. And Ulrike, we are really looking forward to your comment on this meta-analysis. So Tawfik, the floor is now yours. We are very excited.
Thank you very much. So thank you for the opportunity to present our paper in this webinar entitled Endoscopic Ultrasound versus ERCP-guided primary drainage of inoperable malignant distal biliary obstruction, systematic review and meta-analysis of randomized control trials. So I have no conflict of interest. So as you know that ERCP with stent placement is the gold standard approach for primary drainage in malignant distal biliary obstruction, MDPO. Recently, endoscopic ultrasound guided biliary drainage, EOSPD, has been demonstrated as a conservative rescue option in cases of failed ERCP. The aim of our meta-analysis was to assess the performance of EOSPD compared with ERCP as primary options for biliary drainage in those patients. So we included patients with MDPO who underwent EOSPD versus ERCP as a first-line approach. The primary outcome was the technical success rate. Secondary outcomes were a clinical success, incidence of adverse events, mean procedure time, 1 year stent patency, re-intervention rate, and mean overall survival. So here you see the Prisma flow chart. We started our initial search with 443 papers. Among them, 229 and another 9 papers were excluded due to several causes, like EOSPD performed not at a first-line option, performed not because of the MDPO and other reasons. Finally, we left with 5 RCTs that included 519 patients. This table shows you the baseline characteristics of the studies that we include in the meta-analysis. The first three studies that were published in 2018, all of them performed EUSPD with self-expandable metal stent. One of them was multi-center, two of them were single-center. The most common cause of MDPO was pancreatic head adenocarcinoma, and the CBD diameter ranged from 12.5 until 15.7 millimeter. In the right side, you can see the recent two RCTs that were published 1 year ago, almost in gastroenterology. The element study with the Durambo study, they performed EUSPD with lumen opposing metal stent. Both were multi-center, and the most common cause of MDPO was pancreatic head adenocarcinoma, and the CBD diameter was larger than with the SEMS, ranged from 15.9 until 18 millimeter. So we will dive into the results. You can see here the pooled technical success rate that was similar between EUSPD and ERCP, 92.6 in EUSPD compared to 89.2 in ERCP. With the pooled RR of almost 1, there was no significant difference. Similarly, the clinical success rate was again the same, 85.4 in EUSPD. ERCP was 87.7 with pooled relative risk of almost 1. Regarding the stent patency rate, although that the rate was slightly higher in EUSPD, 85.1 compared to 76.2 in ERCP. However, this difference did not reach statistical significance. On the other hand, the re-intervention rate was significantly lower in the EUSPD, 11.4% compared to 17.6% in the ERCP, with pooled RR of 0.58. Regarding the adverse events, again, there was no difference in the adverse event rate. In the USPD was 14.3% compared to 19.8% in the ERCP. And for severe adverse event, there was the same rate of 0.8% for each. Regarding the mean overall survival, so EUSPD showed a standardized mean difference of 17.5 days in favor to EUSPD compared to ERCP. This table shows you the subgroup analysis for the primary outcome, which is the technical success. In this table, we try to assess which parameter might improve the technical success rate, and I highlighted in red and bold, and you can see that including more than 100 patients performing multi-center studies performed after 2020, and including patients with CBD diameter of 16 or more millimeter were all associated with a better technical success compared to the counterparts, which is less than 100 patients and single center and others. And another subgroup analysis in the USPD group, we divided the USPD to either self-expandable metal stent or lumen opposing metal stent, as we compared USPD with the SEMS with ERCP and EUSPD with lumens versus ERCP. And you can see that the technical success rate was better and was significantly higher in the EUSPD when performed with LAMS compared to ERCP, while there was no difference when performing EUSPD with self-expandable metal stent. On the other hand, the re-intervention rate was better and was lower when performing EUSPD with SEMS. In the last row, you can see the procedure time. It was significantly lower when performing EUSPD with LAMS, while there was no difference between EUSPD with SEMS and ERCP. And this could be understood because mostly in EUS LAMS, we are doing a one-step maneuver without manipulating the guide wire. This table shows you the detailed adverse event. You can see the first three studies performed EUSPD with SEMS. 5 patients developed abdominal pain, acute cholecystitis in 1 patient, bile peritonitis in 2 patients, and acute cholangitis in 1 patient. In the last study by Bark, there was 2 cases only of food impaction, while in the studies performed with EUSPD with LAMS, 10 patients had acute cholangitis, stent misdeployment in 2 patients, migration in 1 patient, perforation in 2 patients, and other causes. And if you look to the other side, the dysfunction and the impaction, only 2 cases in the EUSPD with LAMS had food impaction. So the lower re-intervention rate that we've seen in our meta-analysis is probably related to the duodenal bulb site of the stent insertion, which avoids the bile duct and decreases the risk of stent involvement by the tumor. The better technical success that we've seen in multicenter, more than 100 patients, and after 2020, probably due to the increased experience with the EUSPD, and the technical success that we've seen that was better with lamps and the lower time, shorter a procedure time with lamps compared to, and SIMS compared to ERCP. As I said before, probably it's because the nature of the procedure of lamps when we are performing without guide wire in one-step maneuver. We've seen as well that EUSPD with SIMS had a lower re-intervention compared to lamps. So this here could be, in fact, explained by two maybe reasons. First of all, the higher stent length in EUSPD with SIMS could better protect from obstruction and probably food impaction. On the other hand, in one study by Bayik et al., that included SIMS, he included 32 patients who failed SIMS and underwent gastrostomy, and finally it was considered as a SIM success. So this might in fact impact slightly and bias the results. The clinical success rate that we've seen that were similar, probably it's because in some studies deferred ERCP cases were treated efficiently by EUSPD and they're when considered as ERCP success. Limitations. First of all of studies enrolled patients with unresectable conditions and dilated CBD. Therefore, the result of our meta-analysis could be only translated to this specific population settings. Some studies lacked operator blindness, which might affect the performance of the endoscopist. As you saw in the table, the cause of the MDPO among the studies was variable. This trend on the other hand, that we included RCTs with well-defined outcomes and high methodological quality, except for only one paper. Thank you very much for your listening.
Yeah, thank you, Tawfik, for this wonderful presentation of your study and the whole group. So I'm now waiting for Ulrike. Ulrike, I thank you for joining, and now we are interested in your comments on this very exciting paper, Ulrike. And yeah, please.
Yes,
Okay.
my interest disclosures. I just want to summarize the meta-analysis shortly and then go straight to the questions. The meta-analysis we heard about it. There were 5 randomized controlled trials analyzed, and there were 3 multi-center, 2 single-center trials. 3 of these trials used fully covered metal stents for insertion of the bile duct, for draining the bile duct. And the newer ones, the Element and Rambo trial, published in 2023, both used lumen-opposing metal stents. And one thing was mentioned already, the study of Park et al. From 2018 included a mixed collective doing hepatogastrostomy and colodochodulinostomy, both US-guided. And the main results, we heard about them. There was no significant difference between technical and clinical success using EOS or ERCP approach. 4 studies analyzed the adverse events without significant differences. 4 studies, the 1-year patency without significant differences. But there were some significant differences. The EOS approach showed a lower re-intervention rate and a longer overall survival with a mean advantage of 17 days and a shorter procedure time. In the subgroup analysis, using this EOS approach was showing a higher technical success if the bile duct was larger than 16 millimeters. And comparing lumps versus fully covered metal stents, the lumps showed a higher technical success, and the fully covered metal stents, a little bit surprising to me, a much lower re-intervention rate. Summarizing this meta-analysis is in line with previous meta-analysis, which included retrospective and second-line therapy data. And now I want to focus to 2 slides with questions. And probably the first question is that we have to discuss. is the stent patency and the rate of the stent re-intervention rates for the US group really equal or lower than that of the ERCP group? Looking into this meta-analysis data, we have a mixed collective containing lumps and fully covered metal stents, with an advantage for the fully covered metal stent that is to discuss. What are the reasons? Is it probably the longer length? And there are some conflicting data published within the last 2 years, dealing with the stent dysfunction rates of lumen opposing metal stents for the EOS approach. One is the prospective trial, the Scorpion trial, that shows 55% stent dysfunction with lumps CDS within 6 months. And then there was another prospective multi-center study from Vanilla at co-workers. They showed about 32% stent dysfunction within 166 days. And their significant risk factor was the presence of a duodenal tumor invasion, probably a duodenal stenosis. In a French prospective study, there were analyzed 2 risk factors for stent dysfunction. One was a duodenal stent, and the other one was a bile duct less 15 millimeter diameter. And at least a meta-analysis of 12 studies showed a lower rate of adverse events at all, including the stent dysfunction, when a lump stent with a little bit higher diameter, an 8 millimeter was chosen. Normally, we use for this intervention a 6 millimeter lumen-opposing metal stent when we do an EOS approach of the main bile duct. And that's question 1. Probably we can discuss, and if there's time, we can go to the second slide with questions. Then one question I have is it really making sense to put a single double plastic pigtail after insertion of the lumps as a routine to prevent stent occlusion? So what's your opinion?
Very much,
Thank you.
Ulrike. Yeah, Tawfik, please.
Okay. Thank you for this comment. I think first of all, inserting double pigtail stents into the lamps, there is a previous few studies that shows, and there was even a randomized studies that showed that there was no difference in the adverse event in the re-intervention, whether we are inserting a double pigtail or not. So I think today, according to the data, I think it will not be needed. There is another study that is running, started 2022, and the protocol of this study is published in the trials journal. It's doing the same. It's aiming to assess whether the double pigtail will prevent a re-intervention, and there were less adverse event. So today I think there is no need, because there is previous data. Maybe we could consider it in a CBD less than 15 millimeter, because there is some data telling that once we are inserting the lamps, there is a decrease in the pressure, and the contralateral wall might compress the inner side of the stent. So maybe we can consider it in this condition, but as a usual, I don't think that there is need to insert a double pigtail stent. Regarding what you said about stent patency and re-intervention, I think there is a difference, because regarding the Scorpion trial, if we dive into the results, they defined that even persistent jaundice was considered as a stent dysfunction. And the other studies defined stent dysfunction where there is obstruction and need to take the maybe food impaction out, stone, or there is a tumor in the stent, the putting stent. So I think the definition between the studies is still not validated, and it's not universe. So I think that regarding the high rate that you stated in the stent dysfunction in the Scorpion, I would slightly think about it, because the definition was including persistent jaundice, that even after the LAMS insertion, there was no improvement in the bilirubin level.
Shall I ask a question?
Sure. I have all the 2 questions, but go ahead, please.
I also have 2 questions. So please go on.
A lot of questions are coming right now, but Ulrike, please.
Should we go for some analysis of some risk factors for stent dysfunction? Should we head to the problematic patients, for example, the patients with duodenal stenosis due to the malign invasion, or and then say, okay, these patients should get a prophylactic double pigtail, and they should get probably a duodenal stent after inserting the lump stent to prevent food impaction? Should we think about that?
Yeah, I think the most common important risk factor for stent dysfunction and food impaction of the lumps is when there is a duodenal stenosis. I think this is the most single important risk factor. And in the study by Vanella, the 31.8% stent dysfunction, they had there almost 50% of the patients. They had duodenal cancer invasion, and some of them has duodenal stenosis. So I think those patients, if we decide to go and to put lamps, it's better to do gastroenterostomy at the same session or a few days later.
Okay. Peter, you have questions as well?
Yes, you didn't mention the word pancreatitis, and I was wondering, was pancreatitis not at all important, or is it just a minor factor in this procedure?
No, it's a minor factor. Most of the post-pancreatitis, they were in the ERCP group. There was no pancreatitis in the EUSPD.
Of course, as expected, I would say. And my second question is, if you're going to drain a bile duct yourself, are you going to choose a LEMS or are you going to use a SEMS? And why do you have a preference?
So I think to perform EUSPD with the lamps, we have to be in the optimal condition. First of all, we need, I think, the minimal CBD diameter of 15 millimeter. We should assure that the patient didn't have a duodenal stenosis. And in case of there is optimal position without kinking of the scope and a large CBD, I think the first option is to go with the lamps and not SEMS, because with SEMS we are manipulating the guide wire, and I think there will be more adverse event compared to lamps. Again, we should select the patients correctly. And for performing lamps, we need to at least to have a 15 millimeter of the CBD or more.
Yes, but the reintervention rate is, of course, lower with SEMS, huh?
Yes, as we shown in our study, and we think we postulate that maybe the longer stent length that it's within the lumen is the protective factor from the stent obstruction. On the other hand, if you look for the EUS lamps, 10 patients in both studies had acute cholangitis that weren't due to obstruction, because those patients may develop some syndrome where there is a stasis of the contents into the CBD, and you might have a cholangitis without obstruction. So I think further studies are needed in this issue to in fact to see if there is a difference between SEMS and lamps. There is a few studies that were published, one of them in surgical endoscopy in 2021. There was no difference in the adverse event rate and reintervention between EUSPD with SEMS and lamps. So I think we need more data in this specific issue.
Okay.
So the jury is still out. That's what you say, yeah?
Yes, we need more data.
Helmut, please.
Yeah, I have a question as well. You showed that in both groups, roughly the success rate is about 90%. So that means in 10%, say, fail. Was there a crossover? So if ERCP fails, then EUS-guided drainage and vice versa? And how good is the success rate in the second attempt?
Okay, there is a few studies, almost 3 studies in the ERCP. There was a rate of a crossover from ERCP to EU SPD in almost 10%. So all of them that failed ERCP, they crossed over to the EU SPD, and they were all succeeded. On the other hand, there is almost 5 to 6% in the EU SPD that were crossed over to ERCP. So yes, there was crossovers of patients in the both groups, and they were all succeeded.
Mm-hmm. And another question, in the previous paper on ESD and EMR, we discussed about high volume centers. So this is also something special, I would say, like ESD. So not everybody, I think, is very trained and familiar with this technique. So what's about the learning curve, and who should start or do this technique with EUS-guided drainage?
I think there was a previous, maybe recent study 1 year ago in endoscopic ultrasound. The learning curve for starting to practice EUS PD mainly with lamps, you need, I think, 24 to 30 cases to do. And I think we can do it in case, again, an easy choledochoduodonostomy where there is a good position, there is no kink of the endoscope, and there is a large diameter of the CBD. In cases if we need to do EUS lamps in CBD 15 or less, I think we need more expert center, and to practice the mastery, we need more than 50 to 80 cases. So basically, if we will start to do this procedure, we need at least 25 cases of EUS with lamps.
Mm-hmm. Mm-hmm. And if tomorrow you have in your unit a case with a bile duct obstruction, which technique would you use now out of any clinical trials? What is your first choice?
Lamps.
Lamps.
Yes, without guide wire.
Lamps without guide wire.
Yeah.
Okay. A couple of questions are in the chat, so maybe we have time in the last minute.
The last one is definitely interesting, I think, to ask. And that is, what is the expected rate of biliary leak peritonitis in EUS-BD? And does stent type make a difference? Tawfik or Ulrike, maybe?
Yeah.
Yeah, can you repeat? I did not get the question really.
It's in the chat. So the question was the rate of biliary leakages and peritonitis for EUS-guided drainage.
Yeah, I can do a comment, and as you see on this slide, we have a certain rate of stent misdeployment. If there's everything going right with this technique, there is nearly no biliary leakage or peritonitis. Normally, if everything goes right after the investigation, a patient should be fine, and the patient should have no pain and no peritonitis. If you use lumps, the rate, if it's placed correctly, the rate of peritonitis is nearly 0. The problem with the lumps, and I think with the SEMS also, is the question of stent misdeployment, and we have there some rate of stent misdeployment even in expert centers. In these studies here, there was a rate really low of 1.7% altogether in these meta-analysis studies of stent misdeployment with the EUS-guided route. And they did rescue ERCP and rescue ERC or PTCD, as you can see on the slide here. And this is rather low rate. And we have other data, probably a little bit more real-world data from this review of 25 studies. They show a rate of lamps misdeployment of 5.8%. Thereof, about 86% could be rescued endoscopically, and about 10% not with this EUS CDS route. Therefore, we have to discuss that high expertise or sufficient expertise is necessary to place this EUS-guided stent. It's not really important if you take these lumps or the SEMS in certain cases. I think you should always keep in mind that there is probably the stent misdeployment can be a problem.
Okay, thank you for the comment. Tawfik, any other comment? Maybe a last question regarding bleeding. Is double pigtail a useful tool to avoid bleeding?
I think it's not the case like a pseudocyst that we have a bleeding after 3 or 4 weeks. Mainly we are performing a double pigtail when we want to prevent obstruction or food impaction. So I think it's not an issue to prevent a bleeding.
Great. So thank you to our presenters, to our commentators for this presentation of 2 very important papers. My take-home message is ESD and EOS-guided drainage is still something which needs expertise, needs high-volume centers, and I hope our participants agree. And ESGE offers a lot of opportunities to learn this technique, and therefore I was happy that we had almost 200 participants today. Now, I would like to close the session with a couple of slides for our participants. So first slide shows you that the ESGE research grants are now open for the application. This is a great opportunity for all of you who have brilliant research ideas, and I think it's a very exciting tool to support research in our community. So please go on our website and have a look. The next slide shows a very, very important date. So the abstract submission is open since this week, and the deadline will be 12th of November. So we would be happy if we can, as in the last couple of years, increase the number of abstracts year by year. So it's really fantastic what we saw in the last couple of years, that since we have the ESGE days, every year we could increase. Last year we had almost 1,400 abstracts, and maybe next year in Barcelona we can top this number. And the next slide, for those who don't know the ESG Academy, a very nice tool, especially for our young endoscopists, but only not for those, a very nice platform for training. Please have also a look on this web page. And finally, you see ESGE is getting younger and younger, and this is because we have so many young members, and we want to motivate all young people to become members, take benefits of our ESGE, and hope to see you next year in Barcelona. But before we meet all in Barcelona, where we will have a couple of wonderful webinars, and the next will be on the 2nd of October. Very challenging title. No, I don't need the surgeon. I can close by myself. I'm really curious where there will be some surgeons also in the audience, and you see the moderators, and join next webinar. And finally, a great thank you to David Inke and Gabriela Wager for giving us this excellent support, having always no technical problems. Thank you to both working in the background. And now it's time to say goodbye. See you soon. See you in the next webinar.
Thank you.
And enjoy the evening.
Helmut.
Bye-bye.
Enjoy your evening. Bye-bye.
Bye-bye. Thank you.
Thanks.